Good morning, Rob. Can you hear me well?
Yep.
Perfect. All right. So our usual disclosures, our opinions, and our usual disclosures, nothing has changed. These are recorded sessions, so uh, unless you want your dog for posterity on YouTube, try to keep muted. We'll call upon you. Um, Use the chat function as much as you want. It's very useful. I can see both at the same time. And then the QR code at the end of the session is for CME. So let's get started. Today, the topic, I thought that we should take a little bit of a look into the world of the volume waveform as much as we can. And so I'll ask, as usual, for any of our fellows if they want to volunteer to read this waveform. And have no fear. Any of the fellows wants to read it? All right, maybe I have to trigger a little bit the thought process here. So let's start with with this one. So the tag. Uh, so usually when we're reading the tag for a mode, I mean here I made it a little bit easier and just put the mode on its own. But as we know, the mode by itself does not necessarily give you the what exactly the ventilator does. But in this case, this is a servo U ventilator. So the tag is pressure control. So, and we know that because the pressure is constant throughout the breath. Um, but more than anything, we look at the flows and we see that all the flows are different. So the ventilator is not controlling the flow, controlling the pressure. When the ventilators are very good at controlling flow, so it's pressure control. And then the next one is usually a little bit tricky. Is what's the breath sequence? Um, and the way that I like to see this is I start by seeing the breaths, and you immediately see the color change on each one of these breaths, which tells you that there is it's a patient trigger breath, or at least the ventilator thinks that it's a patient trigger breath. Although there is some features that tell you that that is indeed the case, the pressure is dropping for each one of the breaths. So this is a patient triggered breath. And then you look at the cycle, and the cycling in this case, you can see that the flow is actually, there's a good clue over here. The flow is ending at different levels, and it all of the breaths have the same I time. And unless you are pretty robotic, this is a classic. The only way to control the I time is to have the I time set beforehand. So this is consistent with all the breaths cycled by time, which would make each one of these breaths mandatory. So they are being cycled by the ventilator. So if the ventilator controls any of these variables, so controls the starting or the end, then it immediately becomes a mandatory breath. So because all the breaths that we see here are mandatory, and we don't see any other breath, this is definitely CMV, or control mechanical continuous mandatory ventilation. Um, any questions so far? Chase, is my voice better now? All right. And then, yes, thank you. So finally, the targeting scheme. And so the targeting scheme for pressure control on this mode, you can see for each one of the breaths, the pressure stayed exactly the same. There is no other evidence of anything going on here. So this would be what we call set point, meaning the caregiver, the respiratory therapist, physician, nurse practitioner, APP, whatever you want. Set the pressure for the ventilator and set the I time for the ventilator, and that's what the ventilator is going to be delivering. Rob, any comments so far?
Nope, it's good.
All righty. So that's to the targeting scheme. Let me ask the audience, what do you think is the load? And you can put it on the chat. All right. So Mohammed just put one. So tell us what do you think is the load for this ventilator for this patient? I'll give you a second. Tap it in. Yeah. Very good. So several of you thought that this was related to PMOS or patient effort. So during inspiration, without a doubt, what you see is you don't see the normal nice decay that you would expect to see in a passive patient, and so it should look like that. And instead of looking with that decay, there's this flow that actually looks increased or moving up or away from the baseline. You can see that it varies from breath to breath. So that is very suggestive that this patient has PMOS during inspiration. And then during expiration, you also see, instead of the nice, beautiful decay that you would want to see during expiration, in which it should look like that, you actually see that the flow is trying to go towards baseline. So that means that there is inspiratory effort, or away from baseline, which makes you think that the patient is doing expiratory effort. So there is definitely evidence of PMOS during inspiration and during expiration. A common question that we get is this resistive load? Is this the cause of resistance? Rob, you want to comment about that? What happens when PMOS is present on trying to read the waveform?
Yeah, if it's just resistance on a passive exhalation, then you simply have a prolonged expiratory time. Or you have, in the case where the expiratory time is preset, you just get gas trapping. When you see the expiratory flow curve deflected downwards, that means increasing expiratory flow above passive. The only way that can happen is with expiratory effort.
And whenever there is PMOS, is it easy to read the elastic or resistive loads, Rob?
No, PMOS covers up any elastic and resistive effects.
Very good. So it would be hard for us to try to ascertain that there's a resistive component during one of these waveforms, especially when there's active PMOS. Very good. So let's go over the patient ventilator discordance. And so let's start by the trigger. When you see the trigger, every breath was triggered by the patient. It's using a flow trigger. And in this case in particular, what is important for us is that we actually see a drop in the inspiratory pressure along with the trigger in the flow trigger. That is important for us, especially in the setting of what we see on the volume waveform, because you want to be sure that the patient is actually doing effort or manifestations of the patient doing effort towards triggering. So I think every single breath that I see has been triggered by the patient, and I would call this normal unless somebody has a disagreement with that. I see a comment about ineffective trigger, and what I presume that you're meaning is a failed trigger, and I'm trying to find any of the failed triggers. I presume there's concern that if this one over here is actually a failed trigger. I think that that is more likely on the side of the expert pressure. So let's take a look in a second. Sorry, in terms of the cycling. So let's take a look to cycling in a second. So we saw inspiration. Rob, this is a common question we get.
You're breaking up. I can't hear you.
Sorry, Rob. This is something that we get often, which is what is the how do you know that there's work shifting in pressure control?
Well, if there is inspiratory effort, as you've just described, there's clear evidence of inspiratory effort, then by definition, if the patient is doing work, then there's work shifting.
Right. So there's some amount of work shifting on this waveform. This is something that we have struggled a little bit on defining on pressure control. How do you know when there is severe work shifting in pressure control?
Well, if you're asking me, what you look for is the tidal volume delivery. If the patient is doing work, that means he's augmenting the flow and volume. And if the volume is above a safe limit, then I would call that severe.
Yeah. So it's whenever the tidal volume is beyond the achieved or the targeted tidal volume. That's what you're.
Yes.
Yeah. Very good. So in this case, it's a little bit tricky. I didn't put the tidal volume for this patient there, but you see immediately the discrepancies on tidal volume. You have the inhaled tidal volume and you have the exhaled tidal volume, and this is a common issue as you're walking by on the ventilator. Different ventilator manufacturers display the tidal volume differently. Some just display one of both tidal volumes, the exhaled or the inhaled. Some display both, but they give priority to one of them. So if you were walking around caring for this patient and you saw this tidal volume of 282 versus 526, which one is the patient getting? Anybody? Is the patient getting the exhaled or is it getting the inhaled tidal volume?
You have to assume inhaled.
Right. So that's the air that got delivered through that the flow sensor sensed that it delivered to the patient, correct? And then the exhaled is again the same thing that the patient is exhaling and it's coming out of the ventilator. So if the patient has a right, so Ariel says the inhaled passed through the sensor inside the vent, and the exhaled also has to pass through the ventilator exhaled. So if it goes in, if this is your circuit and you have here the ET tube, air goes out and that one gets sensed, and then air goes back in and it gets sent somewhere. Sometimes it can get sensed at the Y, but it can also get sensed in the ventilator on its own. So keep that in mind as we move down to the tidal volume in a second, because that's I think that's relevant for the conversation. So in terms of the cycle, let's talk a little bit about the cycle. In terms of the cycle, you can see that the breath, there's evidence of PMOS, and then you have these little glitches early on during inspiration. Actually, this one also, the peak is not as good. So when I see these ones, in specific 1 and 3, it makes me suspect that this patient has early cycle, meaning the patient was still doing inspiratory effort, and the ventilator cycled because we set the I time on this patient. So because we set the I time, the patient was still doing effort, and the machine cycled early, and there was still PMOS going on. So I think that's what you're seeing, rather than another inspiratory effort on its own. Now, some patients have very rapid respiratory rates behind what the ventilator is giving. But I think that in this case, based on how it looks, this is just a patient that is doing an effort and it's being cycled early. And finally, during expiration, we talked about the work and all of these waveforms that move away from what would be the passive waveform would be what we call expiratory work. Now, in our PV discordance, we never talk about the volume waveform, and that's why I wanted to focus on it today. So when we look at the volume waveform today, you can see that there's a discrepancy, a pretty marked discrepancy between the exhaled and the inhaled tidal volume. So what are the thoughts here? So what is the tidal volume that this patient? What's the importance of this? And I see Steve put a comment here. What if some of the inhaled volume leaks without entering the lungs? And then Chase says, yes, you cannot really tell the effective tidal volume the patient is receiving depending on the nature, severity, and location of the leak. Can you? So I opened the question from Steve and Chase. Which tidal volume is true?
I mean, they're both essentially, Chase, they're both true. The question is, can you know what is actually being a ventilatory tidal volume, like what is actually expanding functional lung and participating in gas exchange? I'm not sure you can really tell, and you kind of would be guessing depending on the nature, where the leak is, wouldn't you?
Yeah, thank you, Chase. Rob, what do you think here?
Well, the first thing is you have to determine, is this really a leak? It has the square root sign like a leak, but there is something else that's weird about it. And what's weird about it to my eyes is that the exhaled tidal volume is always less than the inhaled, but it's radically different from breath to breath. What would cause you to have such a variable leak for the same pressure, the same inspiratory pressure? That seems kind of odd. What if it's not a leak? What if it's just the patient not exhaling all the way because he's breathing like a freight train here, in and out?
Very good. So thank you, Rob, for bringing that. So you just brought some of the differentials for the square root sign. So when you see the discrepancy between the tidal volume, the exhaled tidal volume and inhaled tidal volume, the ventilator will reset to 0 before the next breath. And so the differential here would be that the patient is having a leak, as we suspect. The second one, it could be that there is simply the patient is breathing rapidly and there is some amount of air trapping at that period of time. So that amount of tidal volume got trapped inside the lung and the next breath comes in and the patient is just going fast. Now, if that was the case, would there be a difference through time in the tidal volume inhaled? It should, right? If this is a patient that is breathing faster and he starts air trapping, at some moment the total lung capacity is met, and you cannot expand the lung anymore. And so that's these are usually, if this was a patient that is breathing fast, and you can see that, that's why when they tell me that this is auto PEEP, in general, when you see this amount of air trapping, you would expect that the patient tidal volume would start going down as time goes forward. As it has it, this patient actually has a constant BPF. It's one of our COVID patients with a constant, but he was waking up, and he was waking up, he was starting to do effort on the ventilator. And I think that's what's causing the variability on the amount of the leak, is the presence of PMOS during the the breathing is just changing the thoracic pressures. But coming back to the tidal volume, I don't think there's a way that you can actually know how much tidal volume you're delivering to the patient and ventilating the lungs. This is one of those circumstances in which using pressure control makes more sense to ventilate these patients, because you're trying to inflate the lung. You will not know exactly where the tidal volume is going to be, and it may be very large if they have a very large fistula, but that doesn't mean that the lung is seeing those 700 or 800 of tidal volume coming out of the patient. Rob, any comments about volume control versus pressure control?
No, I think volume control would be a disaster in this situation. And for neonates, we used to always use high frequency because it decreased the amount of leak going out through a BPF. And the other interesting thing is, the gas that comes out of the lungs as leak volume probably carries some CO2. It probably contributes to ventilation.
Absolutely. And this has been, I mean, just going back in time, this has been done in the past, in which the transtracheal gas insufflation, or actually deflating the cuff on the high flow, on the high frequency oscillator, was another way to get rid of the CO2 and clearing CO2. So so that's an important feature. Having a leak will affect the CO2 clearance. As the leak closes, you have to take that into consideration, that the CO2 clearance may get worse. So there's a couple of comments from a man. A positional tray can cause variable amount of leak, which may vary based on patient. Absolutely. Thank you, Aman. So tracheostomies or ET tubes or bronchopleural fistulas, if there's patient activity, that will affect the amount of leak that exists. Are not leaks more prominent during the inspiratory phase when the circuit is pressed? Yes. So that's a great point, Rob. So Rob brings, the other Rob Walsh, brings a point regarding the timing of the leak. And there's leaks that occur throughout the respiratory cycle, and there's leaks that occur only during the inspiratory phase of the cycle. And I'll give you a couple of examples of these two types of phenomenon. One of them, and we have seen this in patients that have issues with tracheostomies, or even with the AT tubes, have been intubated for a fair amount of time, have tracheomalacia, or they have very low compliance and require high pressures to ventilate them. You can't reach the amount of pressure to maintain a safe tracheal pressure, inflation of the balloon, when you're ventilating some of these patients. So there may be or during inspiration leaks. There has been some devices that have been created that actually increase the pressure during the inspiratory cycle of the ventilator. And actually, if you ever do, I have done this, in which you put a transducer into the cuff of the ET tube. Sorry. And what you see is that as the ventilator pressurizes, you see the cuff pressure actually increase during that period of the ventilator, just transmitting the pressure that is coming from the airway.
Yeah, we published a paper on that, Sherry and I think it was last year or the year before, and we showed the waveforms, how that actually happens, like you said. And that leads you to a discussion of the automatic cuff pressure regulators, which in fact are sold with the Hamilton ventilators, and you can buy them as standalone as well. Those cuff pressure regulators only adjust the average pressure. They don't get away from those peak pressures during inflation. So that that it may cause harm if you're increasing pressure during inspiration, or as you say, you might need it just to keep the tidal volume delivered.
Absolutely. And there's other types of leaks in which you may have a bronchopleural fistula, or as they call it, alveolar pleural fistula, in which the leak will be constant. it may, as this is at the end of the airway, depending on the location and how big the hole is, these leaks continuously are putting air out. And evidently, as you pressurize the system to deliver an inspiratory breath, the system will be exposed to higher pressure. And I believe that's part of the rationale of using high frequency oscillations so that you keep a mean airway pressure. You can inflate the whole lung and not having to expose it to the high pressure events to try to heal the hole that has generated. So, and the technology is still available. I wish they would improve the technology so that we can use it a little bit better, because it does make sense under those circumstances.
A question.
Yeah, go ahead, Aman.
So we're talking about the cuff pressures, and I have noticed that, especially in patients who have high inflation pressures, that it goes up significantly during inspiration when you're trying to measure it. So when we are targeting a cuff pressure of less than 30, are we trying to measure that during expiration?
That's a great question. So I would say yes. That's usually when you're measuring the cuff pressure is during the expiratory phase.
Thank you.
But that doesn't mean that it's all a matter of flow, right? So if the pressure during the expiratory phase is higher than 30, then you're going to be compromising the breath during inspiration and expiration. And so that's why you try to keep it below that when you are during expiration, so that the patient gets a perfusion during those periods of time. That's my rationale for that. Rob?
Yeah, and there's this controversy about how to set the cuff pressure. You know, minimal leak technique, minimal occlusive volume, all those things. And there's a lot of, I think, confusion surrounding that. My advice is to have an automatic controller. I don't know that we can afford to do that on all patients, but that's the best way to do it. And the next best way to do it, in my opinion, is just allow minimal leak during inspiration. So you can hear that on the trachea with a stethoscope.
Yeah, actually, you bring a common issue as we're talking about this. This is all mechanical ventilation, but is the issue of using pressure and of forgetting about volume of the cuff that you're putting in. And we've had, so as you think about this, if you're just thinking about pressure, and especially with long-term ventilated patients, tracheostomy patients, you may be increasing the pressure, and as the pressure goes for longer period of time being increased, the balloon integrity or compliance may go down, as well as the wall of the trachea. You may continue to dilate and dilate. And suddenly you draw the air out of the cuff and you have 20 cc's, 25 cc's, and now you have a trachea that is very large and floppy. So the concept here is not only the pressure, but also the volume, and how to have a best practice of saying, for long-term ventilated patients, how do you minimize the amount of pressure that you are and volume that you're putting into the trachea of these patients, and it can become very, very challenging in managing them. Yeah. Another common question, since this is the forum, and I'll put it out, is, can you ventilate somebody with a leak? How? So this is a common item in which we see a leak and we start trying to make everything to occlude the leak, especially when we're talking about a tracheostomy. So we continue to, or a ET tube. So we put more air, try to inflate the balloon more. And so the question here is, when does this affect ventilation? Any thoughts? When would you say that a leak is okay? So there's one that it's when the P-plat is okay, So when you're not over this, I mean, especially if you have pressure control, I don't think that the pressure is going to leak. This is more about gas exchange and maintaining the PEEP, right? So if the patient is having appropriate gas exchange, he can have as much leak as they want. That really doesn't matter, and the mode it would be exactly. So Imran saying maintain CO2. Absolutely, that's a marker. The other one, and we had recently a patient in which they had a massive leak whenever the inspiration went in, but the area that we were focusing was in maintaining PEEP on that patient, maintaining recruitment. And so in reality, during inspiration, the patient could leak as much as they. So that maintains end expiratory lung volume to a certain degree. So very clinical. There's another comment. As long as gas exchange maintains the increased mean of ventilation required to maintain isn't injurious or problematic, let the leak be. Thank you, Chase. Yeah, so that's right. Sometimes we focus too much on them and the patient doesn't necessarily need another interaction. Very good. All right, we talked a lot about let it be, let it be. Let's move on. All right, if there's any comments, just put them on the chat or unmute yourself. Free will it. All right. Is there any fellow that wants to read this waveform? Come on, there must be one of our fellows that is. Amanda, do you want to give it a try? Just for kicks.
Yep, sure.
Thank you.
All right, so the tags VCCMVS.
Yeah.
Oh, sorry, 1 second. All right, so tag VCCMVS, the load is, so I see during inspiration, there's PMUS in the middle of the breath. And expiration looks passive, but I would say ends at about 1.5, maybe resistive. It doesn't quite come back to normal. So I'd say resistive in the expiration. PV discordance. So I see early trigger, and that's leading to breath stacking. And then inspiration, there is some mild work shifting in the first breath. So cycle is, I think the cycle is fine. It's just a manifestation of the early trigger. So I'll probably not comment much on that. In expiration, there's no work. So overall, I would say this is the main issue is early trigger, which is the differential for that would be reverse trigger if everything else, if the patient's like deeply sedated. That's been typically described in literature because it does look pretty symmetrical. So that would be the differential. Other than that, the same old discussion. This may just be patient activity at a particular time, but yeah, that's about it.
So, Aman, great job. Since you can see that we're focusing a little bit on the tidal volume, on the volume waveform. What do you think about it?
So the volume waveform, okay.
Yeah.
So I can see the first and the third breath, the exhale volume is, kind of cut off after a few cc's because, so basically what's happening is after the breath cycles off, the PMUS is still active, so that triggers a new breath after a short while of cycling the first breath. So there's only a few cc's of volume exhaled before the next breath is initiated by the ventilator. So it's just breath stacking. So that's why that the exhale volume is so low in that particular breath.
Very good. Thank you. We'll get. Thank you, Aman. Let's talk a little bit about this one. I really like this image as we were talking about, and there are several items to talk about. So the first thing is the targeting scheme for this mode, and as we have described in the ServoU, volume control can have several tags. It's not just one tag, depending on what button you press. But as you read it correctly here, this is volume control, and you can see how the flow is very well controlled here. It's a geometric shape. It's a descending ramp in which they put a flow pattern, and you can see the flow pattern all the way down here at 20, and 20 means 20% of the peak inspiratory flow. So it didn't go all the way to 0. I don't even know if it's 20% of the peak inspiratory flow. Yes, 20% left of the starting flow. And you can go all the way to 0 to make it a perfect triangle. Why you change the flow pattern, we don't know. I mean, your decision is as good as any. To my knowledge, there is no research on how to set the expiratory flow, and if any of you has that one, I would be interested for volume control in particular. I mean, I know that there has been some studies on how to, if we should use descending ramp or a square wave ramp or an ascending ramp, but not necessarily at where to set this at 20, 30, 100 or whatnot. And you can see that there was PMOS, and actually it was done. So all this is a mandatory breath, and this is cycled by the ventilator. So if it, because both are controlled by the ventilator, then it becomes all breaths are mandatory. So continuous mandatory ventilation, and you set the tidal volume and the inspiratory time, which gives you the S. Now, an important feature to recognize here is this is volume control CMBS. And you see the waveforms, and I've showed you before that sometimes the waveforms may show discrepancies, but on this patient, the circuit compensation, which is a little symbol that looks somewhere like that, is off. So you don't see it on this waveform. Actually, I can show it on you on the, there maybe one there. This symbol means that there is circuit compensation. In this particular case, it was off. Don't ask me why, but it was off. And you can recognize that by the absence of that symbol there. What is the load? I think that you read that appropriately. PMOS during inspiration, and there's no PMOS during expiration. It seems that it's a passive expiration. And then any patient ventilator discordance, we agree with you with the, you can see this is a mandatory breath. And the next one is triggered, and you can see the color change here. And so the ventilator is detecting this to be a patient ventilator trigger. And there is actually evidence of effort. You can see how the pressure drops below baseline. And so that tells us, and with the evidence of PMOS over here, that's all evidence of PMOS, because normally this would have gone up something like that, and then down. And so all of this area that is moving downwards tells me that there is PMOS, and so that's an early trigger, as you mentioned. Rob, any comments?
Yeah, I can't see very clearly, but it appears that both of these breaths are machine triggered for the first of the double triggers.
Yes.
And that's one of your diagnostic features of early triggering. And well, I'll let you continue, but I have another thing to say about tidal volume later on.
Yeah, we're gonna get to the volume of these issues. Very cool. Some work shifting, we agree with you. There's some drop on the pressure, but it's not below the baseline. The cycle, as you said, is technically normal because what you grade is actually the breath that started everything. So this was a mandatory breath, and it has an early cycle, and that triggered the next one, which can or cannot have an early or late cycle. It doesn't really matter. And finally, expiration, which I think that it's normal. It seems passive to us. And then there's the volume waveform, and the volume waveform is a delight to see because it highlights why, as you call breath stacking, double triggering, multiple triggering of breaths is so dangerous on volume control. And so let's just eyeball it for a second. So you can see here where I put the red mark, that's the tidal volume that we set, which was 320. So the ventilator delivers those 320. Then the patient has a small exhalation. So you can see there's one here and there's another very small expirations, in which, at least on this measurement of 320, the patient put out 78 milliliters. And then the patient triggers another breath. And when the patient triggers the other breath, the ventilator delivers another breath. And you can see that it's exactly the same size as the prior one. So one after the other are identical. But the difference here is that if you see the pressure that the ventilator used to deliver it went way up. And that is a manifestation that this patient got this tidal volume on top of here. So essentially, if the graph was not reset, the tidal volume would have gone all the way up here. And then the patient starts exhaling all the way to get to zero. And that's why you don't see it disappears out of the scalar, because it's going negative, because it's now exhaling the tidal volume from before and the tidal volume that you delivered. So these two are coming out now, and then the patient gets another breath. And actually, you can see that there was an amount of air trapping in this passive expiration. So this tells us that this patient is not only getting extra tidal volume for every time that the patient has that increase, and number two, that there's an amount of air trapping. So now you're over distending, you're getting extra volume on top of that volume on top. Go ahead, Rob.
The interesting thing is, if you look at the digital display, it looks like there's nothing wrong.
Yeah.
It looks like you got an inhaled tidal volume of 320, just what you have said. What's the problem, right? But if you recall that the area between the flow curve and the horizontal axis to time axis, that's proportional to volume. And as you can see, the first two breaths, you get to 320 mLs, but the big exhalation is twice that area. So that's really what that inspired tidal volume was for that particular exhalation.
Exactly. So and there's no alarm. I mean, to my knowledge, there's no ventilator currently that alarms under these circumstances. That that first recognizes a multiple triggering event and alarms for it, because it's relevant regardless of the mode. If you have multiple triggering, it could be a leak, it could be disconnection, it could be a just early triggering, early cycling. I mean, you name it. There's some action that needs to be done by either the ventilator automatically or by the caregiver. So this is very, very distressing, I would say, in general terms, when we see this. So that's probably a call to our manufacturers to start thinking more intelligently about the alarms in the setting of patient-ventilator interaction. It's 2:52. We're about to, I don't think we're going to have time to do the next case, but any questions or comments so far?
What'd you do for this patient? How'd you fix it?
That's a great question. So I'll open it to how do you guys deal with early triggering? And I'm looking at the chat to see, or if anybody wants to unmute. How do you usually, what's your number one behavior?
It depends on like why the patient has early triggering. If it's like just for like over sedation or something like that, I would start with decreasing patient sedation and see if that will help or not, the reverse triggering. But if there's another reasons, or it's because of the timing of like the eye time, or because of any other reason, I try to fix the mechanical ventilation settings, see what exactly the patient wants. Sometimes I put them on pressure support to see what's the volume the patient wants and what's the eye time, and then trying to mimic that and making sure that I will not go out of the lung protective umbrella to keep the patient safe. That's how I do it. I don't know if that's right or wrong.
Thank you, Mohammed. Anybody else?
Can I make a comment?
Yeah, go ahead.
I mean, it seems to me that this is a immediately life-threatening situation. And all those other comments about sedation and adjusting settings, those are valid, but my concern would be over the next few breaths, this patient, if he was already set at 6 or 7 mLs per kilogram, he's getting twice that. That could be life-threatening depending on what his lung condition was to begin with. So if nothing else, you would switch him to pressure control, because if he still continues to have an early trigger situation, it's not going to be as bad in terms of the volume delivered. And then from there you can adjust and try to get rid of the synchrony problem. That's just the way I would do it.
Great point. So and this asks for what I would think is an algorithmic thought process of how do you approach the management of certain desynchronies. For early trigger, there's some pathways that may be more effective at decreasing harm than others. And if you see multiple triggering, there's pathways that may also prevent that. So and also you have to put it under the context of what is the etiology of or not etiology, what is your goal of mechanical ventilation? If I see this in a patient in which my goal is comfort, I mean, this patient should not be on this mode. As somebody suggests, as Ariel suggested, I would put them on pressure support, see what happens to that patient. But without a doubt, if I had to choose for a patient in which is having early triggering consistently, pressure control over volume control will always beat in terms of volutrauma, because the patient will not be able to get as much air inside the lungs under those circumstances. Yeah, very interesting. Very good, team. We had other cases, but this is good enough. Here's the CME code and the QR code for those of you that want to get a CME. And then, as usual, send us your images. Happy New Year for all of you, and thank you for listening and joining. Have a great day.